Here on GameChangers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count. Hey CEimpact subscribers, and welcome to the GameChangers Clinical Update Podcast. I'm your host, Rachel Maynard, and today we'll be discussing a drug that's been around for decades, but is still continuing to see a rise in use, gabapentin. And this increasing use of gabapentin isn't new either. We first saw headlines about this from 2002 to 2015, when gabapentinoid use more than tripled over that time frame. Since then, some states made policy changes to address this, like including gabapentin in prescription drug monitoring programs or reclassifying it as a Schedule 5 controlled substance in an effort to limit inappropriate gabapentin prescribing. But now we have some new data on dispensing rates, and that brings a fresh opportunity to continue to reevaluate appropriate use of gabapentin and the importance of balancing safety concerns with potential benefits. So to help us clarify the role of gabapentin, I am so thrilled to welcome our guest, Dr. Nakia Duncan. So welcome, Nakia.
Hi.
So Nakia, can you share a little bit about yourself? So maybe your background, your current role, and why you're interested in this topic.
Yeah, absolutely. So thank you for having me here. I appreciate it. And as far as my background, I am a pharmacist, a clinical pharmacist, as well as an associate professor for pharmacy practice. And my practice site currently is in a pain management and palliative care role. So for the most part, I work with patients daily that are suffering with pain, and I see a lot of gabapentin use. I say a lot of it on label and off label, kind of to foreshadow some of our conversation. So that's the reason why I'm interested in this topic and working with pain management and palliative care. I also see some concomitant medications that sometimes can make gabapentin use tricky. So yeah, just really excited to talk about this topic.
Excellent. Yeah, I am really looking forward to having your expertise on this because I think this is a challenging area often for the reasons you said. And so learning from some of your experience, I think will be great. So thank you so much for your time. So we're going to start out, I think, with just a little refresher on gabapentin itself and we'll be looking at efficacy and safety, but let's look at that efficacy side of the coin first. And starting out with those, you sort of alluded to the FDA-approved uses versus the off-label uses. So let's start with those FDA-approved uses first. I think we know there's a lot of off-label uses too, but let's start with
Yeah.
the FDA-approved ones first.
Yeah, and honestly, there's only two. There's one for post-herpetic neuralgia and focal seizure onset. So those are only two that are FDA indicated. I feel like a lot of times people don't even remember those because there's so many others that we use gabapentin more for in the off-label arena.
Right, absolutely. So it is surprising when you just sort of hear that narrow focus, and I don't think most
Yeah,
people taking gabapentin are taking them for seizures. So
yeah,
yeah, I think that just
yeah,
kind of segues nicely into those off-label uses and
yeah.
beyond those approved uses. What are the most common off-label uses that we see in practice? And let's also talk about the evidence for those or lack thereof, because I think that's a really important part of this discussion.
Yeah. So whenever I was kind of just going back and looking through this, I saw like around 10 or so off-label indications for gabapentin. Some of the ones that are more common are going to be things like restless leg syndrome, some of our pain syndromes like fibromyalgia, neuropathic pain syndromes. We also see things like alcohol use disorder, as well as we see some other um, things like hiccups, chronic cough disorder. We also see utilization for menopause or vasomotor symptoms, to name a few. There's probably some I'm definitely leaving out, but these are the ones that come to my mind.
Mhm.
Probably because I see them a little bit more frequently, but there's some with regard to like, yes, less utilization, like general anxiety disorder, insomnia, um, anxiety. And I think that maybe I see those a little bit less due to maybe limited evidence and with regard to utilization.
Okay.
So I think your question was like, here are all these off labels, right?
Mhm.
So which ones have any evidence? Which
Right.
ones should we
Yeah.
kind of like start working or thinking about?
Um, Also in night review, I kind of look through some of the ones that I use frequently, like neuropathy, and fibromyalgia. And I feel like they have a good amount of evidence, for the use of gabapentin in that area over time. We see that it does show to have good analgesic benefit, with a mild side effect profile, for both conditions. Another area that I see that has good data is whenever we're using it for alcohol use disorder, it's actually been incorporated into the VA DoD guidelines. So this
Okay.
is another strong area that we can use gabapentin with some confidence that it's with confidence. Um, Areas that kind of have wax and wane, that might be because maybe a lot of people don't have intractable hiccups. It's kind of a condition that we don't see very frequently. So it doesn't have like a lot of evidence there. We're mainly seeing case reports with like an N of one or two, but it makes sense, right? Again, it's like we
Yeah.
don't have a lot
Yep.
of people with intractable hiccups, but in those small case reports, we did see promising outcomes for gabapentin.
Okay.
Some things that have limited, as I mentioned, general anxiety disorder really limited there. We don't see strong evidence, not even in case reports, for the utilization of gabapentin or adjunctive therapy, for that. So those are the ones that kind of come to mind.
Yeah, I mean, as you're going through those examples, which are as I think we can hear, just sort of spanning the spectrum of various types of conditions and concerns. I think of this phrase of like throwing the kitchen sink at something. It's just like it's
Yeah,
this drug that may be tried for all different kinds of things with varying levels of evidence to support those off-label uses. So I think that what I heard is neuropathic pain and alcohol use disorder are some of the ones that may have, even though off-label, may have more evidence to support use than maybe some of these other uses. Even anxiety, and I think you mentioned sleep too. So would you call that on
yeah.
the sort of less or mixed evidence to support use for those indications?
Yeah, yeah. And I would say probably with regard to insomnia or sleep is probably the least. And I was unable to really find much at all. I think that's really an anecdotal
Okay.
um, kitchen throw, if you would
Yeah,
say, with
yeah.
regard to gabapentin. So yeah,
Okay. And I mean, that actually it sort of transitions into the consideration of the safety profile of gabapentin because you might think of it for sleep because sedation, sleepiness, drowsiness, those are potential side effects of gabapentin. But in terms of targeted use for that reason, we may not have the evidence to support that. So let's go ahead and
correct.
talk about the safety side of things now, that safety side of the
Mhm.
coin, and thinking about, we're talking about this continued increase in use. So with that comes potential safety concerns. And what are those safety concerns that we should be thinking about most commonly with gabapentin?
Sure. I think the major side effects for gabapentin are going to be CNS related. So they're going to be, these are the things that we predict. These are the things that when I start a patient on it, I warn them about. It's going to
Hmm.
be like dizziness, somnolence, drowsiness. And those are things that, I expect could happen. But some other things that we're being careful about, in particular, if your patient has like renal
Hmm.
insufficiency, could be those dramatic or exaggerated responses. So they may even have like ataxia. It's possible that they could also have, if they have like an anaphylactic reaction to it, which I haven't seen too much, but just to cover it, it could
Hmm.
be like hypersensitivity or DRESS or even Stevens-Johnson syndrome. Those are things that could happen with gabapentin. But as I mentioned, the more common ones are the ones I mentioned. Also, with older adults, I always think about dry mouth. There is a little bit of anticholinergic activity with gabapentin. So, in combination with other anticholinergics, we can get a burden, which can cause some GI, or I'm sorry, to cause some dry mouth.
Hmm. Hmm. Yeah, and so I think you summarized that well. And the point about, especially in combination with other anticholinergics, that concern about dry mouth, I'm thinking about also the issue of gabapentin in combination with other CNS depressants, which you alluded to, but
Yeah,
specifically with opioids, for example. And there is a box warning
yeah.
about this combination of gabapentinoids and opioids. And Maybe you can speak about that a little bit too. That's I think something that is within the last 5, 6 years that that box warning came out, but definitely something to be thinking about, especially because we've talked about gabapentin use for pain, and so thinking about it either as a substitute for an opioid or as an add-on to an opioid, where do you start in terms of sorting out some of those challenges and concerns? What would you summarize for our listeners?
Yeah, I think whenever I think about this and kind of even hearing this topic, I kind of, my brain went back, like you said, about thought almost 10 years, honestly.
Is it okay?
Gabapentin being, yeah, honestly, I
Yeah.
went like, whoo, went back there. And the reason for that is because about 10 years ago, we saw the opiate crisis happen and,
Right.
be labeled as the opiate crisis. And in 2016, the CDC issued this, statement saying, hey, we need to really monitor opiate use. And subsequently, at that time, we started seeing a gabapentinoid increase,
Mm-hmm.
right? And I
Mm-hmm.
think that what the thought was is that gabapentin was less of a concern or even a mild or non-concern, right?
Mm-hmm.
And
Mm-hmm.
over time, when we have relaxed and kind of like come a little bit out of the opiate crisis, we see that that increase in gabapentin use had some effects where in combination with opioids and other CNS agents, we did see some marked increased CNS effects. So a long-winded way to say that, it's not a benign medication, which I believe that we at some point felt like, even though there's a label that says CNS depression, we felt like it didn't have too much of an effect. I really
Mm-hmm.
think that it's a cumulative issue as well as an individualized, if your patient already has sensitivities, that it could exacerbate those CNS sensitivities.
Mm-hmm. Mm-hmm. Yeah, absolutely. So just I to sort of call out that point that you just said that it's not necessarily a benign drug. I think that's just so
Mm-hmm.
important. Really, to me, a key takeaway
Yeah.
from this discussion is that like with that balance of potentially limited evidence for some of these off-label uses in particular, and the potential safety risks that you just talked about, that risk benefit balance doesn't always make sense for all patients, and like you say, it's
Yeah.
not benign, and you work with older adults, and in particular that's something to be aware of, especially in the context of renal impairment or polypharmacy, some of these other considerations. So
Yeah.
yeah, anything you want to add to that thought or
Yeah, no. I think you're definitely driving it home there. I mean, another thing I see sometimes in practice is that, for whatever reason, maybe an older person comes in, they have an AKI, and we stop gabapentin for a bit, and then they remember they have it in their house, and then they get back on it. But in that time frame, they also got on other medications,
right,
and
right.
then there was this forgotten, like maybe just didn't even make their providers aware of it because they had permission a while ago to use it, and now they got back on it and now
Mhm.
it's like, oh, I'm so tired. I'm so sleepy. Mom had a fall. All these kind of things are happening. And sometimes it's not inherent, like why this is happening. And
Right,
then,
right.
without having that good discussion about like, oh, this is the gabapentin that could be causing this because of all those shifts and changes and fluctuations in medication utilization.
Absolutely. Yeah. Yeah. I love
Yeah.
how you're calling out, that this was, I remember when the box warning about opioids with gabapentinoids came out, and it was challenging because many people were taking them together. And so the concern around how do I explain this to a patient, what the risk is. But I think what you're hitting on is sort of this idea of any minor other change in medications, change in health status, change in hydration, all of these things could sort of tip that balance into potentially increased risk for serious side effects.
Yep, that's exactly what I'm saying. Yeah, definitely. And, different subsets of patients are at higher risk. I mean, I've said older adults a few times, but as I
Hmm.
mentioned, I work with patients that are in chemotherapeutic regimens, and that's another really high risk. A lot of times having dehydration, and a risk of patients who are frequently on gabapentin. Maybe they're on it for an indication I didn't talk about, but chemo-induced neuropathy.
Oh
They could
yeah.
be on it for
Okay.
that.
Yeah.
Or,
Yeah.
yeah, that's another indication. And sometimes just even malignancy or chemo induced. So sometimes they're on it for that. And we know that they are at risk for dehydration and
Yeah.
frequent rapid status changes. So, it can get misconstrued for chemo brain, or maybe even potentially like,
Right,
oh, is something
right,
going, the patients are get a little nervous, like, is something going on with me? And, we look, and I think, looking at the timeline, when did this happen? Oh, it's when I started the gabapentin. Okay,
right.
well, let's talk about that.
Right, right. So yeah, keeping it top of mind, I think, is one of the things that is going to be, um, to me, the recent data that we have now on the rates of prescribing dispensing is a reason to keep gabapentin top of mind and dig a little deeper in some of those conversations, especially
Yeah.
if issues are cropping up. So I just think that's a great point to highlight. Um,
Yeah.
so now let's move on to some of the data that we've been sort of dancing around, and just dive right
Yeah.
into that, because I think this is
Yeah.
a great opportunity for us to think about why this sort of increase in use is continuing to happen and what that will mean for practice. So we had a paper that was published that sort of spurred this discussion in the first place. So maybe you can speak a little bit about that, Nakia, and sort of what were the takeaways from that new data.
Yeah, so there is like we've been talking about an article that came out. It looked at the gabapentin trends over almost like 14 years, 2010 through 2024. And the main thing is they were looking at the dispensing trends in retail settings just to kind of see like what's been happening. And one of the strongest things I got out of that is that they found out that the dispensing trends within 2010 to 2016 doubled. They had this doubling of that amount of how many were there. I believe it was, I don't know, I don't remember the exact number, but it was a double in their number on how
Yep,
many there
yep.
were. And
Millions
then
of prescriptions.
millions, it was millions. I knew, I
Yeah.
didn't know exactly what it was, but I knew it was a lot, and it was a lot.
Yeah.
And also in that paper, they also found that older adults showed the largest growth in that time post 2016. And again, that was almost, it wasn't exactly double, but almost in that way. So we're seeing a large increase in that. This article also highlighted that gabapentin is currently the fifth, medication that's dispensed, fifth most dispensed medication on total, right? So
Hmm.
that's like, we got a lot of meds. So, and if it's
Yeah.
coming up as the fifth ranked, it really kind of showed that, and basically that we're really using this quite a bit in the retail pharmacies. Um, One thing that I kind of in evaluating this article, like in my mind, I thought through, I said, well, we captured all the pharmacies. I think this number could have been even underestimated because
Yeah.
in this article, they looked at like retail settings, but they kind of
Hmm.
excluded long-term care facilities. They excluded mail order pharmacies,
Hmm.
pharmacies that are
Hmm.
inside of a hospital. So it could probably be even more
Hmm.
gabapentin dispensing that we had that's available. So
Yeah.
those are some of the things I saw, just kind of brief highlights, but I don't know if you want to chime in a little bit or have anything
Yeah.
that, yeah,
Yeah, yeah. I mean, to me, again, the punchline was the fact that among all of these medications in the US dispensed by community pharmacies, given those limitations that you said, it may not be counting other practice settings, but that gabapentin was the fifth most dispensed drug in the US in 2024. I just think that is such really an astounding number, especially considering the
yeah,
off-label uses that you discussed versus the approved label
mhm,
uses, and the fact, to me, that suggests that a lot of this prescribing is likely off-label and
mhm,
potentially with limited evidence to support it in some cases.
mhm,
And just the fact that I had mentioned earlier how initially, sort of around that 2016, 2015 timeframe, we had originally seen these increases in gabapentin prescribing. And then we had the opioid guidelines that came out and that also further impacted practice. But the fact that despite all of that, where we've come from 2016 to today is still continuing to see the rate is not as high as it was originally, but it's still
sure,
continuing to go up. And um, that, I think, again, really speaks to the fact that people are looking for options for managing
hmm
various conditions. and often reaching for gabapentin, it sounds like, based on the
Yeah.
data we have that we just looked at. And I guess, to go back to the opioid guidelines and how that might have impacted practice, because I think that ties in really importantly with this discussion, is,
Yeah.
when you see these numbers and the fact that rates are continuing to go up, what do you think are like the primary reasons why this is happening? Is it because people are using it primarily as an alternative to opioids, and is that appropriate? What do you think are some
Yeah.
of the reasons for this trend?
No, absolutely. That's exactly what I thought. When I first saw this, I looked at the article and I was looking at the data between 2010 and 2016. Another thing I looked at was the types of prescribers. So in 2010, if you look at pain medicine prescribers and you look surgical prescribers, they were barely prescribing gabapentin. But at the end of 2016, their numbers doubled and tripled with regard to
Wow.
prescribing of gabapentin.
Wow.
So that
Yeah.
told me something, typically pain medicine prescribers and post-surgical or probably would have been using opioids, right? But
Mhm.
then when the guidelines came out, they're like, no, you can't do that. It's attributing to the, crisis.
Mhm.
Granted that the 2016 guidelines may have been a little bit knee jerky with that, but it still prompted like this shift where
Yep.
we need
Yep.
to give patients something, right?
Right.
But I don't want to give them an opioid. I don't want and who's going to follow them after to keep giving them the opioid. So then we're grabbing for something that maybe can work, but we don't know if it will work, but at least it's something. And I felt like
Mhm.
that is what happened with gabapentin. It got thrown
Mhm.
in this. Maybe there's partial evidence. There's so much other off-label use of it. Maybe it can work here too. And I think that that's what we saw increasing and increasing. And then because of that, if it didn't work, then we just have a bunch of gabapentin being
Yeah.
auto refilled
Right.
and sitting in
Right.
people's sitting in people's houses.
Right, right. And so how would you address that head on if you had a like if you were talking to a prescriber, a colleague who's has a patient with pain, thinking about an opioid but wanting something safer for that patient, how would you sort of put the role of gabapentin into context for that? Obviously there's a lot of patient specific factors that need to be
Yeah,
considered in that
sure.
scenario, but as a general reaction, like you say, again, towards something else instead of opioids, where would you sort of categorize gabapentin in managing pain broadly? I know that's a
Yeah, I
hard
think what's
question.
important. No, 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 no. I think what's important in context of this conversation is to again go back to the beginning. It's not a benign drug, right?
Right,
It
right.
has its own
Yeah,
effects,
yeah.
right? So we, even though maybe it's not, an opioid, it does have concerns. We have patients that are continuously fluctuating. It's a with fluid renal insufficiency. We don't know what's going on with them from that standpoint. It does potentially cause in a like increases in dizziness, somnolence, and those things. So it's not benign. So we can't just
Mm-hmm,
think of it in that way, right? So
mm-hmm,
I would first hope to educate them in that perspective, and then also let them know that by adding it in, it just increases polypharmacy for those patients, and then
right.
maybe even throwing off another cascade that we're going to have to loop around and deal with later. So it may be more appropriate to be judicious with your opiate prescribing, have rules, have boundaries, have lower doses, have shorter frequencies and timeframes, instead of just throwing in medication that really doesn't make sense, but also could actually increase harm in other ways
Mm-hmm.
that we don't intend.
Hmm. I think
Yeah,
that's a great
that's a
takeaway.
conversation.
Yeah,
Yeah,
I think we automatically think of risks with opioids and maybe not as automatically think of those risks, similar risks that can
yeah,
often crop up with gabapentin too. Even misuse is a concern
yeah.
with gabapentin too. And
Yes.
again, the move towards some states making it a controlled substance speaks to that. So I think that's a great perspective to, again, keep in mind. So, thinking about sort of tying this all together, and we've seen these increasing rates, especially in older adults, and taking this as an opportunity to help patients navigate safe use of gabapentin. What are some of the top tips that you'd want our listeners to think about in terms of if they're reevaluating the role of the gabapentin for their patients, or they're seeing new prescriptions coming in, or refills, coming through, and this conversation is top of mind, what would you advise them to be thinking about or looking for with these patients who are either starting or refilling gabapentin, let's say?
Yeah. I think, with regard to thinking about, I kind of try to put myself in this place. And I said, well, if I was a community pharmacist, a lot of times these prescriptions come into me, it's just gabapentin. I don't know
Right.
why the person's on it, right? I think what could be helpful is including a note to them, including in your person, it's for restless leg syndrome, it's for chronic cough, so
Yep.
that
Yep.
the retail pharmacist can be equipped with an opportunity to look better for drug-drug interactions, to provide more efficient counseling for the patient, because they're really the first line that in the community for those
Mm-hmm.
patients. So I think that's really important. I think, as the ambulatory pharmacist, helping to give that education that gabapentin can be used differently. I think as a pharmacist that is working collaboratively with providers, giving education on all of these different miscellaneouses of their off-label use, letting them know about the varying levels of limitations in their limited studies, which ones have better data, making sure to refresh our providers on, new data that comes out on gabapentin and its potential harms that might happen. I think that also partnering with our healthcare providers to let them know, hey, make sure to add in your indications, because that helps our
Absolutely.
whole team, right?
Mm-hmm.
Helps everybody, right? I think that these are just, really simple things that, in a way, we just don't think about it, but they're like small, soft touches that really enhance the quality of care.
Mm-hmm.
And from the patient perspective, like whenever we're counseling our patients, also in a way telling them the same thing. This medication, while it's not a controlled substance, it can still have these, concerns. If you notice this, if your heart doctor says this, please communicate it with this. If your renal doctor says this, please communicate it with this doctor, to try to empower them to make sure that everybody's communicating.
Mm-hmm.
I think pharmacists are in such a unique position because we see all of the prescriptions coming in from all of the providers. So we're able to kind of disseminate that information back out and educate patients appropriately. So these are just some things I think about that could really help on all aspects of it whenever it comes to gabapentin use.
Absolutely. I think you called out a few very great practical, takeaways. And yeah, you had alluded to earlier the idea of this prescribing cascade, and I think that's also a great
Yeah,
opportunity for
yeah,
pharmacists to be staying alert for new symptoms patients may be reporting. And like you say, having to dig a little bit deeper to see, is that a new symptom? Is that from a new condition or existing condition? And thinking about gabapentin or any other medication the patient is taking for that matter as a possible cause.
yeah,
Because
yeah,
we were chatting before the podcast started about
yeah,
this report where
yeah,
somebody had fluid retention, a diuretic was added, increasing the risk for falls, and that fluid retention was due to gabapentin and not identified, and that
yeah,
led to this prescribing cascade, as you say. So, just a really good example
yeah.
of interventions that pharmacists are just in a great position to be able to make.
Absolutely. Yeah. Whenever I was training, one of the things that my mentor would say, any symptom should be considered a side effect until
Yes.
proven otherwise.
Yeah.
Right?
It's a great.
I don't know if all pharmacists heard that, but I did. She was always telling me that any symptom, it's kind of until proven guilty,
That's right.
until, you kind of like, it's a side effect, and figure it out, dig deeper.
Yeah,
I feel like that's what pharmacists are trained to do, dig deep and figure it out. So I would encourage us to keep digging with gabapentin.
absolutely. Yeah, I
Yeah.
love that phrase. Guilty until proven otherwise, with a side effect instead of
Yes. Yeah.
yeah, that's great. That's a great pearl. And just to think about for patients who maybe are thinking about discontinuing gabapentin or switching to something else, what are some
Sure.
safe and practical tips that they may need to be aware of? Do they need to taper?
Yeah.
What are, again, this news may sort of prompt some new discussions. And so if we're helping
Yeah.
patients switch off or discontinue, what are some key things to keep in mind there?
Yeah, it does depend on this clinical situation, but generally speaking, we do want to taper down off of that as well. Kind of the same way we got on, the same way we will get
Sure.
off, of the
Right. Yep.
gabapentin. Maybe not identical, but kind of slowly moving off of that. And the reason for that is that it is stimulating some of our CNS receptors, our gabapentin in our brain. So kind of quickly removal of that could cause some agitation. It could cause some discomfort. So it's nice to kind of move down in a slower fashion, so long as there
Mhm.
isn't any harm being had with the gabapentin. Then, of course, we would have to remove it more quickly.
Okay,
Yeah.
good to know. Yep. So that's about all the time we have. So I just wanted to wrap up. It is our Game Changers Clinical Updates podcast. And so we always wrap up with a game changer. So, Nakia, what would you say is the game changer that you want our listeners to walk away with about this discussion about gabapentin today?
I want our listeners to know that gabapentin, despite the fact that it's not a controlled substance, it is not a benign drug. Remember that gabapentin should be monitored, it should be educated on, and dig deep a little with gabapentin. Make sure that we're using it in a good way, we're using it in a responsible way. So that's my game changer.
Excellent. Thank you so much. And thank you so much, Nakia, for your time and taking time out of your busy practice. We really appreciate your expertise on this and really practical examples. I loved it. Great discussion. Thank you.
Thank you so much.
So listeners, be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.